Hey, good morning. Happy Monday. My name is Lisa Tyndall. I am responsible for clinical trials here at the Foundation. It gives me great pleasure to welcome two of our esteemed MHI physicians here to talk about diversity and equity in healthcare. Before I bring them up, I wanted to thank our sponsors here today, Amgen, Tim and Ellie, and AstraZeneca. Thank you for your support. If you have a moment, stop by and say hello. Dr. Courtney Baechler is the MHI cardiologist and medical director for the Emerging Science Centers here at the Foundation. And then Dr. Bennett is a heart failure physician and a MHI board member. And both of them I'm lucky to have as physician investigators. So with that, I'll turn it over to Courtney and we'll get started. Thank you.
Right. Good morning, everybody. Thanks for being here, those of you that are in the room and those of you that are far. First, I just want to talk about our CV Mobius trial. Do I do click share? Oh,
you're talking about the trial.
should I just put that? I think sorry, and then I'll go to it. Just want to make sure folks know about one trial that we're enrolling in, our CV Mobius study. This is specifically in partnership with Amgen, where we are looking at PCSK9 inhibitors. These are one of my favorite types of trials where we know that PCSK9 inhibitors decrease the risk overall of cardiovascular disease, but we haven't studied them in a real world study. So this folks can have any type of ACS event or have had any type of PCI, both from a peripheral vascular disease and coronary perspective. And within 18 months, we will roll them into this study looking at PCSK9 inhibitors in addition to whatever else they were doing. And then we follow them for 5 years. So this could really change how we practice going forward, taking a look at these outcomes. So. But
if they're already on the statin, do you switch them or are they in addition to?
It's in addition to. So yeah, so their LDL just has to be above 70 and you have to be not making any plans to, changing to a higher dose plus that. But as long as they're in a deemed clinically stable point cholesterol wise, then this can be something that we add to. So yeah. All right, now I go to click share. Is that right? And do I have to touch something up here?
Just that white button.
Okay, wait, sorry, which button?
The click share button.
Oh, but I don't know what click share is. I feel like I need this button.
Yep.
Oh, yay. Okay, good. So far, the morning's going well. So really excited to be talking about health equity today and have some partners. Dr. Bennett and Dr. Gössl will also be talking about work that they're either doing or interested in doing. We have a packed agenda, but I just want to start by bringing us to our mission here at the Heart Institute and Foundation, really creating a world with heart and vascular disease for all, right? And so just from the very beginning, this is not something new. This has been our goal all along, and we're just taking a look at where we're at and what we're doing. So I'm going to start big, go small, start big, go small, both nationally and at the state level so that you guys can see the facts and figures. But here's what we know. So African Americans have higher death rates than whites for 12 of the 15 leading causes of death overall. We know specifically that Black and American Indians have higher age-specific death rates than whites from birth through retirement years. When we look at Hispanics, they have higher death rates than whites for diabetes, hypertension, liver cirrhosis, and homicide. And unfortunately, as you'll see throughout these slides, minorities get sick younger and have more severe illness and die sooner than our white counterparts. I think it's important to take a look back historically. So we often talk a little bit about historical trauma and the impact that that's had in people seeking care, enrolling in trials, all sorts of things. Unfortunately, this goes back, over 400 years when we first look at early settlers. From the very beginning, there's been disparities between Blacks and whites. I'm sure many of you know about the Tuskegee syphilis trials, but this is not long ago, and this is where specifically Black men were being studied for syphilis outcomes, and despite when we did have cures and antibiotics for this, we're not offered that. And this is something that frequently within the Black population, people reference family members relatives that they know that were actually a part of this. What's important, as I was doing my own research on this, I was just looking at the historical side of things. And as early as 1990, so not long ago, at an esteemed academic university, they were doing a study of, quote, the genetic etiology of aggressive behavior. And what they did was only enrolled young Black boys. They withheld water, took away all their medications, including asthma medications, gave them fenfluramine, and then kept them up all night and monitored blood draws without their parents being involved in this actual evening overnight, and then tried to say that there was a genetic correlation between aggressive behavior and being Black. So this is in the 1990s. This is not long ago. We've got lots of work to do. What I can say that I'm so proud and continue to be proud of what we do in cardiology is aggressively look at research and outcomes. And you'll see that in some of what's been done in the last couple decades here. So in 2002, the Institute of Medicine put out a report, The Unequal Treatment Disparities in Healthcare Delivery, which was really revolutionary, looking at just overall treatments in a variety of areas. And one that they drew, that they emphasized was cardiac care, and that specifically there was some disparities in cardiac medications being prescribed, as well as CABG, and who was offered it, who was ultimately given it. And then in 2004, there was a systemic review of angiography, angioplasty, CABG, and lytics that looked at 23 large trials, and 21 out of the 23 showed that African Americans were less likely to get CABG. So I think it's important as we talk about, like, what is race? And this was something that was put out in '96. And so it's dated, but still rings true today. And I just love the quote: "Pure races in the sense of genetically homogeneous populations do not exist in the human species today, nor is there any evidence that there have ever existed in the past. Biological differences between human beings reflect both hereditary factors and the influence of natural and social environments. In most cases, these differences are due to the interaction of both." When you look up the Human Genome Project, it turns out that we are 99.9% similar. And that really, race in terms of when we look at it that way, is about 0.01% different in our genetics. So really understanding the social construct and what's happened with race, while of course, again, as we look at these studies, there's huge difference in outcomes, it doesn't appear that there's any genetic basis for that. So let's look at some of those elements. So when we look at the national statistics, what we see is that Blacks have the highest rates of heart disease in the country. They're 2 to 3 times more likely to die from heart disease. And while the cardiovascular mortality rates have been decreasing, this is not seen from our Black population. And when we look at specific things like ICD implantation in the Medicare population, if you're Black, you are 42% less likely to get an ICD. Here's a study looking at hypertension prevalence by sex and ethnicity. And so you can see in the highest columns, that's our Black population. And we can look at the total and then breaking it down by both men and women. And you see the whites and the dark blue columns having the much lower comparison, Asian and Hispanic, not quite as low, or sometimes lower, than the white population, but unfortunately the Black population having the highest rates. When we look at diabetes and overall outcomes between Blacks and whites, you can see, again, a disparity in overall hospitalization rates, with Blacks being more likely to be hospitalized, less likely to have their glycemia controlled, less likely to have their cholesterol controlled, and less likely to have their blood pressure controlled. I put this in just to set up the next slide that I have in here. But when we look, we all know that diabetes is not helpful as it relates to cardiovascular disease. And you can just look overall at the relative risk of cardiovascular events in men and women with diabetes. And you can see, again, when we look at women and men, unfortunately, women do worse with heart failure, coronary heart disease, MIs, and ultimately coronary mortality. And then when we couple that together and look at being both gender and being Black, you can see Black and Hispanic women have the highest rates of obesity in the country. Black and Hispanic women have the highest rates of diabetes and high blood pressure. And women and Blacks overall were less likely to get a cardiac catheterization when they presented with chest pain than men and white equivalents. So again, we can go just about down any cardiovascular outcome and look at this. Here's looking specifically at atrial fib. So we know Black and Hispanics actually have a lower incidence of atrial fibrillation than whites. However, Blacks are less likely to be aware they have the condition. They have an overall higher risk of stroke and stroke mortality in the Black patient population, greater risk of major bleeding with warfarin. However, there's been no difference noted with DOAC use. And you're going to hear more about heart failure specifically from Dr. Bennett at the end here. But when we, another area that's been looked at was heart transplant wait times. And this just compares 2014 and 2016. This is something they're looking more closely at in terms of how long folks had to wait. In 2014, African Americans waited on average 19.8 months compared to white patients at 12 months, Hispanic patients at 12.3. And then in 2016, it was a little bit closer, but still a disparity with 10.4 months for our African-American population, 8 months for the white population, and 7.4 for the Hispanic population. So again, when I go back to being really proud of the work that we've seen cardiologists lead, credo, I don't know if how many of you are familiar with this group, but the Coalition to Reduce Racial and Ethnic Disparities in Cardiovascular Disease Outcomes was started in 2009. And this was really based on those landmark studies that we saw from the Institute of Medicine and the large trials review showing that these big disparities existed. And the goal here was to help the cardiology community meet the needs of an increasingly diverse patient population, have evidence-based tools, performance improvement data. I mean, really a lot of the things that we try to do here with HDI, provide education along with cultural competency, educational approaches for patients, and with the goal being equitable care and outcomes for all patients, regardless of race, ethnicity, sex, and age. And Dr. Yancey really helped spearhead this. And, you know, part of this was based on what our population looked like in 2008 and what it's likely to look like in 2050. You can see here, well, in 2008 and still today, the white population makes up the majority. That is not looking and won't be the case as we continue to move forward. And we see all sorts of races coming into play in larger proportions and the need to understand how we best take care of various populations. They did some studies, this is back from 2011, but interviewing cardiologists, do patients receive different care based on race and ethnicity? And I think this is very interesting, right? So overall, cardiologists thought yes, people in general in healthcare and specifically in cardiovascular disease do get different care based on race and ethnicity. However, when it comes to your hospital and the way you treat them, there was a thought that that we didn't treat them any differently individually or in our own health system, which again, I think is often sort of our perception, but somehow, somewhere along the line, there's something happening here. And this was specifically looking at door to balloon times and differences, which again, there was a statistically significant delay in door to balloon time in both Black and Hispanic populations compared to their white counterparts. So we talked about looking at things at the state level and then, at the national level, and then looking at things in Minnesota. As I've talked about, lots of pride in cardiology and definitely pride in Minnesota cardiology. We have actually had the best cardiovascular mortality rates since 1999 in the state of Minnesota compared to anywhere else. But then of course, you have to look at the data a little bit more closely, and do we see that for all of our patient populations? And unfortunately, right here in our backyard, we don't see that. So when we compare specifically looking at African-American cardiovascular mortality rates and American Indian mortality rates, higher in each decade until the 70s, specifically for our Black population, and then 80s, we see doing as well as their white counterparts. And we can break this down again so that you can actually see our ratios as well as our crude death rates. Again, to the earlier slides, we see these higher rates of mortality in younger age groups. And then if you live long enough, this leveling off here. So we have work to do in our state. And if we look at some of the risk factors, we see the same thing. So this is all data that's available through the Department of Health on risk factors and ultimate outcomes that are collected statewide. And when we look at blood pressure control, comparing now this year, specifically comparing to our Minnesota healthcare program members, which was essentially the state plan in 2017. If you had higher numbers, that's better in terms of, again, the blood pressure control, and lower being worse. So again, when we look across here, the Black population had the least control of the blood pressure. When we look at optimal vascular care, again, we're going to see similar outcomes, unfortunately. So looking at non-smoking, blood pressure control on an aspirin, and on a cholesterol-lowering medication. If you were Black in Minnesota or American Indian, you were least likely to have those at goal. When we look at stroke, in terms of death rates, again, we see compared to our white population, African Americans and American Indians doing worse. So I was just talking to Dr. Bennett about this. In 2014, Dr. Ellinger, who was Commissioner of Health at the Department of Health at the time, really made health equity a big part of the agenda for the Department of Health. And as you can see here, when we look at describing what this is, health equity is a state where all persons, regardless of race, creed, income, sexual orientation, gender identification, age, or gender, have the opportunity to reach their full health potential without the limits of structural barriers. And I want to show you a video that just...
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-ville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of B-ville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, B-ville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are B-ville's many liquor stores, fast food places, or convenience stores. The schools in B-ville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of B-ville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and B-ville get so different? Well, in many cases...
All right. Escape again, John. Is that right? Okay. Okay. One more time, you think? Or should I like end it and show? Isn't it funny how you can do these things at home and then when you're in front of a room? I swear I can do them at home. Anyway, so I think that video does a great job of showing how this can happen. Now, again, I think the natural instinct is to think, but it's not like this in the Twin Cities or in the state of Minnesota. And the American Heart Association has done a great job of showing, actually, we have some of the largest disparities in the entire country. This highlights, again, Medina and looking specifically at Elliott Park, which is right by Riverside and not far from us, as well as Rondo and St. Paul, which is a historically Black community. So we see these same disparities in life expectancy here. So the Department of Health and state of Minnesota, given all of this in 2014 under the leadership of Dr. Ellinger, started the Center for Health Equity to really look deeper into this and see what we have going on here in Minnesota. One of the things that they did was do a statewide health assessment to look at who is healthy and who isn't, because again, if we don't break things down, sometimes when we look from a population perspective, we can't see what's really happening there. And I'm just going to show you some of the data that we had from that. So here, what we found was 14% of all children in Minnesota live in poverty. About 9% of Minnesotans 18 to 64 have a disability. 1 in 5 families with children have a child with special health needs. As we talked about, we looked at those maps nationally. Racial and ethnic diversity is expected to increase here by about 25% by 2035. The LGBTQ population in Minnesota faces many health challenges and barriers to health, and overall, our population is aging. So when we look at opportunity, we're really talking about the chance to experience success at every stage of life, from early childhood through old age. And our opportunity, we know, is shaped by many conditions that constrain or expand the choices available to us. So we're really looking to make it easy for folks to have access to schools, jobs, and have a permanent home to find what we need to stay healthy. So let's just look at what we see, again, in our own state here in Minnesota. Education is one of the clearest and strongest predictors of lifelong health. And I just want to put in a personal plug as we're thinking about COVID, that we don't forget for the children how impactful health is, or excuse me, education is to long-term health. It's easy to get lost in what we're seeing right now, but again, we see some of these disparities in who is getting school and not right now. So in the state of Minnesota, when we look across the span in terms of graduation rates, we see our American Indian population with about 53%. On-time graduation, our Black population was 65% compared to our white population at 87%. When we look at the connection between education and health, looking at diabetes, for instance, less than a high school diploma compared to a college degree, a much higher prevalence of diabetes. When we look at prenatal care and inadequate prenatal care, when you have less than a high school diploma, you're less likely to get that leading. We know the second most impactful predictor is the education of the mother. In terms of long-term health of the child. And then when we look at smoking, we also see this strong correlation between education and health. Without a high school diploma, being much more likely to continue to smoke. Income is another issue that we mentioned before. So when we look at poverty within the state of Minnesota, the overall white population has about an 8% poverty level, as opposed to our American Indian and Black population in the 40 percentile and 41st percentile. We also see these disparities in the urban and rural environment, and that you're much more likely to be living in poverty outside of the urban area. Home ownership, this is another really important thing to look at. So we see our white Minnesotans being 3 times as likely to own a home compared to our African-American counterparts. And when we put this all together, income, housing, and health, and look at a variety of diseases, you can see, again, when people were financially stressed about their housing, the likelihood that they had these various conditions. And so we looked again at cancer, COPD, arthritis, depression, diabetes, asthma, cigarettes, binge drinking, and obesity. And we see these strong correlations with income, housing, and stress about those. Additionally, when we look at belonging and feeling safe outside and being able to move, we see that white Minnesotans are twice as likely to use regional parks and not note safety concerns, as opposed to our populations of color being more likely to note concerns about safety in parks. And then when we look at obesity, which we know is such a big risk factor underlying all of these conditions, again, breaking down various populations, we see our American Indian population at 41% obesity, our Black population at 25%, and our white population at 27%. And then finally, when we look at disparities in our prison systems and jail, this slide is outdated, not correlating with accurate representation of our population currently, which for Minnesota is about 8% for the Black population. But you can see a disproportionate amount of both Black and American Indians and Hispanics in our prison population. So we know populations of colors and American Indian and Minnesotans experience consistently lower opportunities to education, employment, income, housing, transportation, paid leave, health insurance, and health care. I feel very lucky. So part of my role at the Department of Health before I came here was over the health equity department for the state of Minnesota, which is part of why I got so passionate about all of this. I've continued to stay on over the Minnesota Maternal Mortality Review Committee, which looks at all deaths from moms. And in the state, we actually will be meeting this afternoon. And I think many of you know that one of the biggest contributors is cardiovascular outcomes. But what I wanted to call up here is part of what's happening nationally. Again, unfortunately, we see these same racial disparities in our maternal mortality outcomes, and what the CDC nationwide has proposed is adding discrimination as a cause of death. So as we review cases currently in terms of what contributed, what was preventable, this year that has been added as a category, just like opioid abuse or poor prenatal care or hypertension. So that's part of what's down the pipeline. And it was done in part by Dr. Rachel Hardiman, who is a PhD scientist at the University of Minnesota, and was the woman one of the authors that wrote Stolen Breaths in the New England Journal of Medicine that came out shortly after George Floyd's death. So getting back to the unique role that we can play, we have always, our goals here have really focused around research, community education, and clinical outcomes. And I would argue because of areas that we've been very successful in, that we have such a great opportunity to be a leader in this area and doing even more. One of the areas that we're exploring right now is working with IHEAL, Insight Health Equity Lab, which is a group on the north side that has done some pilot studies specifically working with the African American population in working around empowerment, engagement to help folks reduce risk factors of obesity, high blood pressure, diabetes, cholesterol. They did a small pilot study with Mayo back in 2015 and had some great outcomes in terms of getting people more active, increasing fruit and vegetable content, et cetera. But we have had the great opportunity to have some conversation with Batala and Al McFarland, who have led Insight News and have really brought together storytelling, the community connection and trust to be working in partnership with other folks on the north side to change these going forward. And this is something that you'll continue to hear more about as we look at what that might look like long term. What I would argue is when we think about what we've done with the Level 1 STEMI program, with HANU, with our ability historically and ongoing to create very strong relationships in our community, as well as being a national, having a great national reputation in research, that we're poised to really make a difference in this work and to really go back to having this be amazing cardiovascular outcomes for all, not just a select population. So with that, I'm going to turn it over to Dr. Bennett.
Good morning, everyone. Thanks for the opportunity to share a few thoughts and data with you. Dr. Baechler, thanks for the opportunity to add to this wonderful presentation. So, I'll just start with some more information specifically related to heart failure that really mirrors what we've heard already. We know that the prevalence of heart failure is higher in African Americans. There's 6.5 million people in the United States with heart failure. And when we look at heart failure both by age, gender, and race, we can see that the incidence, the risk of heart failure increases as we get older. And this risk of heart failure is highest in African Americans. This red bar here are Black males. And particularly at a younger age, 55 to 64, we see this disparity, this increased risk of heart failure compared to white men. When we look at mortality, we know that heart failure mortality, a diagnosis of heart failure gives you a 50% mortality in 5 years. Again, when we look at age-adjusted mortality by race and gender, we see that Black men have a higher mortality across the board. Now, this is at least 2.5 times higher than white men. And in the younger populations, this disparity is more pronounced. Another striking feature of this information is that since 2011, heart failure mortality has actually been increasing in African Americans. So another aspect of this that I'd like to draw your attention to is that in general, African Americans are poorly represented in heart failure clinical trials. When we look at 25 randomized clinical trials in heart failure over the last 30 years, 19 of those for drugs, 6 of those for defibrillators. All of these studies together total roughly 79,000 patients. Less than 5,000 are Black. And the median participation of Black patients in each trial was 162. And then if you look over at a graph of this over time, you can see that as in the black line, as overall patient enrollment increased, as the study population got bigger, the percentage of Black patients actually decreased. And that's probably the thing that stands out the most about this is that there's this disparity in the size of the study and the percentage of Black participants. And the take-home message here is that Black patients are poorly represented in these pivotal trials. And without inclusion, it's hard to ensure that the findings of a study can be generalized to all patients with heart failure. I want to draw your attention to 2 specific studies, and here's a list of the 26 studies that were looked at in heart failure. There's VHEFT, a 1991 study that looked at isosorbide dinitrate and hydralazine compared to an ACE inhibitor. There were a total of 804 patients. 26% of them were Black. That's actually pretty high comparatively when you look at all of these. And AHEFT, a 2004 study, which was looking at the effects or the mortality of isosorbide dinitrate hydralazine versus placebo in only Black patients. So this AHEFT trial was it really came out of a sub-analysis of the earlier VHEFT trial, which suggested that the combination therapy of nitrates and hydralazine was beneficial to Black patients. When this was looked at closely in AHEFT, there were 1,000 patients, all Black. Their ejection fraction was 25%, and there was an 18-month follow-up. You can see that as early as 6 months into the study, there was a survival benefit of this combination therapy, and it only got more significant as the time went on. So what lessons did we learn from this trial? Well, we can spend a whole hour talking about this one trial, but here we have a therapy for Black patients that improves survival and reduces hospitalizations. This was a group that has historically been underrepresented in clinical trials. And by actually looking at this particular population, we were able to get a therapy with a specific survival benefit. This information has been incorporated into heart failure guidelines and is really a good option for patients that are on optimal medical therapy. So we heard how there's disparities of all types, and here's one example of a disparity in access to heart failure care. A 2018 study that looked at the heart failure patients that needed to be hospitalized in intensive care unit showed that Black patients were less likely to receive care from a cardiologist or in an ICU. The other message in this study was that if a patient with heart failure required critical care, their survival care by a cardiologist was associated with better in-hospital survival. There's clinical bias in heart failure as well. 2019 study, a survey of 400 healthcare professionals in heart failure, presented them with this vignette, a story about a patient, and the only difference in the profile was the race of the patient. These heart failure professionals were asked to rate the appropriateness of the patient for heart transplant or LVAD. And amongst the factors that were most important were the social support and assessed adherence of the patient. The African-American patient with the same profile was deemed less trustworthy, had less social support, and worse adherence. I'd emphasize again that the only thing different about these two profiles was the race of the patient. Heart transplant was recommended more often for the white patient. So we've seen disparities nationally, statewide, across cardiovascular disease and in heart failure. It's important that we ask, are there disparities in heart failure care at MHI? We think about the environment in which we work with Black patients at MHI. Black patients represent 11% of heart failure hospitalizations, 14% of advanced heart failure consults, 5% of clinic visits specific for heart failure, 8% of heart failure clinic visits. And this is in a city of 20% African Americans and in a state which is a little bit less than 10% Black. So we should all ask these questions. Is there equity and access to cardiology and advanced heart failure care? Are Black patients represented in clinical trials at the foundation? Is there any clinical bias in consideration for heart transplant and VAD? So what are the factors that drive disparities in heart failure care? And we heard a lot about these from Dr. Baechler, but it's important to highlight them again. There's a social determinants of health, insurance, education, nutrition, housing, transportation, income, healthcare provider discrimination and bias, the reduced delivery of evidence-based treatments and access to care, disparities in participation in clinical trials. Blacks are underrepresented in heart failure research studies. And then the lack of preventive care. So many of these cardiovascular disease are modifiable, and the lack of addressing risk factors early leads to heart failure. So again, we could spend all day discussing how to approach equity and how to eliminate disparities. But I think this first point is probably the most important. We should recognize that they exist and increase awareness. We should work to promote favorable lifestyle changes that we know are associated with the risk of developing heart failure. We need to address structural inequalities in education, income, and health insurance coverage. We also need to change policy in order to expand access to care and the distribution of health services. And we need to educate and train all of us in the reduction of bias, anti-racism, and cultural competency. And then, finally, we need to make sure that we involve everybody, African Americans, in clinical research.
Yeah, so Courtney was asking me to make some comments too. I don't have slides because I showed the slides before. So we have a study going on. It's called Twin Cities, but it's a study that actually now involves 5 centers. So it's the Minneapolis Heart Institute as the leading institution, and we have started with HCMC because we needed more diversity, obviously, in our study. And we now have UCLA, we have Henry Ford, and we have the WashU participating, or at least in the contracting process. And the simple approach there is to enroll patients with a diversity background. That could be race, that could be income, that could be language, anything. So it could be a white person that just doesn't have enough education, for example. So it could be anybody, but to enroll those folks with severe aortic stenosis into treatment. So that could be surgery, that could be any kind of valve, but if they participate or if they qualify for an Edwards Sapien valve, then they actually also get a questionnaire to be filled out because it was sponsored by Edwards. And then they fill out a questionnaire, and the simple questions there are like, did you get enough education about your choices? Was your healthcare good enough? Are you worried about inequity, for example, health insurance, etc.? Lots of questions that you just all approached here. So it's actually very difficult to do this study because, as you can imagine, with us or the United States actually only having like 3 to 5% non-white people in any kind of TAVR treatment, you can imagine how much we have to actually still work in order to reach maybe a 20% level, because that's what should be the representation, assuming the disease is spread in the same way, and it is, as we know from other studies. So it is very difficult to do it because there is a lot of biases on both sides, right? So, we as physicians, and that is a work that was done at the Duke University, the biggest risk factor right now for probably an African American not to receive TAVR is the cardiologist, and I repeat that. So the cardiologist is the biggest risk factor because of all these biases. Yeah. So that's what Duke found out. So basically, the education of a general or even interventional or whatever, whoever does TAVR or refers to TAVR, is just not good enough at this point to actually refer patients to the right treatment. And in the disparity and diversity background patients, it's even worse. Yeah, so there's all these biases, like you pointed out. Anyway, so we are trying to approach this, but we have had success. We have already enrolled now 12 or 13 patients from our side here. The others are starting up. And the goal is just to enroll about 50 in each side and have these questionnaires filled out. And some of the patients that are referred obviously end up not getting an Edwards TAVR. So we probably have approached like 20 or 25 patients, but they might have gotten surgery or anything like that. We just did a little interim analysis of what the patients actually said. So we did patient analysis and referring analysis. About 200 to 300 referral physicians answered our questions here. And the top 3 answers were, I think, that it was felt there was not enough insurance for diversity patients, that there wasn't enough follow-up, that they would not follow up in their follow-up appointments. And the third that I forgot now, but the first 2 ones, definitely the fear that the insurance was not enough and the follow-up was not enough. So the follow-up is definitely a big issue, and that we also identified. The insurance, so it's interesting, the patients, the 12 that have so far filled it out, I know it's small, but it's getting bigger. It's not an issue at all. So on both sides, I think what's turned out to be really a major problem is simply the simplest thing, it's education. Yeah. So if we look at this with our Edwards colleagues, it seems like on both sides still, the referring cardiologists that see these patients and primary care physicians for sure, when I go out, primary care physicians that see patients with diversity background, they have not aortic stenosis in their mind, right? So they think chest pain is GERD, right? So that's how far we are away from, thinking that everybody knows about what valvular heart disease is. And I don't know how it is in, heart failure, but they are so focused on these three major things like diabetes, stomach disease and all of that, that every patient has that. So they first get, treatments that are completely off cardiology treatments, right? And so there's a lot of education that needs to be done on both sides. And the insurance question, for example, as we probably all know, is actually not the biggest deal for the patients, right? So it's not the patient, it's not, that they can't make their own decisions. We ask all these questions. It's really often the piece that they didn't know about their options, that they didn't know what that was, what their symptoms actually were. And the worst thing then is if that patient meets a physician that doesn't know it either, then of course, nothing happens. And unfortunately, it even grows into the subspecialty cardiology where whatever the bias might be, the referral does not happen. So that's what we're seeing right now. But I think it's nice to see that we started this maybe 2 or 3 years ago, and the more people heard of it, the more people actually wanted to start. And it's not like we're making a world change with the study, obviously. It's really not funded that way. But what I can see is that, for example, HCMC is referring many more patients to us than before. So you're creating pipelines, right? And that's not meant to be a business pipeline. It's just meant to be, okay, now I have someone to talk to. And the trust issue that came up, right? So now people come, let's say, to me and say, Mengistu and Mario, they work together. Now I trust this team. So there's a lot of work on that range that needs to happen. So I think from my experience, just limited for 2 or 3 years now, you have to create trust. Like you said, you have to create a community relationship to your hospital and clinic. But once you establish that, patients don't have other biases than that. We think there's something going on that's different. It needs to be just a trust that white patients have to us too. And the educational piece is still missing for severe aortic stenosis, for example. So we still have to work on education and different education than we used to white populations. And I think that's probably what's going to come out of that study. But each institution creates these pipelines. And then if you have more and more institutions doing that, I think then you can increase the population diversity too.
Thank you, Dr. Gössl. So we put this together on the foundation side. Healing Hearts is our mission. We're in this together, and I'm really excited with the leadership of Chris Fortman and the interest going forward, and really having this as a strategic priority of how we make sure that, again, from a research and education and ultimately clinical outcomes, that we are specifically looking at our diverse communities. And as we talked about, while we're likely not fixing housing and income and things like that, we are uniquely poised to make a real difference in cardiovascular outcomes. And I really appreciate what you highlighted, Mario, that I think that trust is critical in how we work with other referring institutions and various neighborhoods. Creating that will really be able to make a big difference, I think, in those outcomes. So we'll open it up for questions. Anybody? I'm glad it was so straightforward.
I'll start out. If I could ask Dr. Bennett a question. When you look at the cause of heart failure in blacks versus whites, I assume we find significant differences. And what is your perspective on that?
That's a great question. Yeah, there's heart failure etiology is multifactorial. In African Americans, you see a lot of the risk factors being hypertension as being a big driver. same risk factors for coronary artery disease, but there are different profiles in terms of what leads to ultimately to heart failure in African Americans.
So, you know, if you trace it back, it seems that our ability to manage hypertension in African American population is, we're still, even though we have great medicines, our penetrance of that population and is inadequate. And do you have any thoughts about that? I know there have been different ways of doing treatment, including non-medical or non-physicians, but I'm just wondering what your personal perspective is.
Yeah, I think that there's, with hypertension, it's clearly early detection is key. And there have been efforts to screen populations for high blood pressure, awareness of targets and aggressive treatment, all of which are lacking. There's room for opportunity there. So I think, you know, it's a relatively simple thing to think about, but really it can make a big difference in terms of outcomes, identifying hypertension, treating it effectively, and ultimately preventing development of heart failure.
Thank you for your talk. It was great. Do you know, Mosi or Courtney, what's the percentage of African Americans in our clinics that we see? I mean, I'm just from a personal standpoint, for me, it's very low. I just, you know, and then what can we do to increase the number of African Americans that we see in our clinic to help?
That's actually quite the very same question that I had as I was putting this together. And we looked at it using our dashboard. So I showed one slide, and that was just a snapshot of percentages in our clinics from 2019. And the percentages are low, less than 10%, approaching sometimes 5%. More closely reflecting the population of Minnesota rather than Minneapolis. And then when you think about the prevalence and incidence of heart failure and coronary disease and valve disease, likely higher in African American community, how do you, what's the right number? What's a good target? I think we can all agree that we should be seeing more. So we don't have a good answer in terms of what that target should be, but certainly I think that our patients are not represented to the extent that they should be in our clinics.
I was just going to say, to add to that, when we were looking at the HCI data, what we did find is when people got to us to this question that Mario was sort of saying, our outcomes were pretty good from an equity perspective. Not that there's not more room because the numbers are so low to look at further. But I think the point being sort of, where do you define the intervention? What we need to do a better job of, I think, is making sure that folks get to us, know that we're a trusted resource, know that, you know, the Tuskegee trials aren't going to be what they see here. And the American Heart Association, the Minnesota chapter, has done some work specifically from a hypertension perspective with kiosks and communities in place where there's higher populations of various racial and ethnic minorities. But on the committees that I've been on with them, because a lot of those were through the Department of Health, what I see is missing is, so then what do you do when you in a community do diagnose hypertension that is more than just prevention from fruits and vegetables and exercise? What are we doing to connect them to trusted clinical care? Are there different types of protocols that we would start with telehealth or nurse practitioners for lower risk areas? Or, you know, I think that's what I see is missing, in that we have some community prevention going on and then some really great clinical care once you get to us. And how do we make sure that people feel trusted here when we're now largely, with MHI East and West, the largest cardiovascular group in the state? You know, then sort of how do we make sure that our population and who we're seeing is reflective? And I think it's that the both sides piece of what do we do from an outreach perspective and how do we create that trust?
Right. So, I mean, are there clinics out there that serve mostly African-American patients, and why don't we do outreach there?
So that's what we're looking at with the slides that I had. So North Point is one of the largest ones, which is not specific to North Memorial. It just happens to be on the north side of town. And again, that group has specifically said that they would love to work with us in doing more from a cardiovascular care perspective. So I think the opportunity is there. And then there's other areas. Again, the Rondo community in St. Paul is another place which would be a great opportunity for MHI East. And various other places. I think it just hasn't been a priority, and it's exciting to nobody's fault that, again, as we look at this data, we're seeing that this is a place that we should be intervening. Yeah.
Online questions here. The first of which is, there's a belief that cardiovascular lifestyle change is most effectively actioned in youth. Do you think that youth are the key to eliminating racial disparities in the long run?
You know, as a preventative cardiologist, if I could do everything in youth, I would, but this is no different than how we treat white disease, right? That you treat it when you see it. And as early as we can go is great. But then again, when we look at what's funded and what we can do now, we usually start more with tertiary and quaternary care. Hopefully, I think part of our goal in working with communities is to be doing it on both ends and be starting generations having less prevalence of all the risk factors, but also we can make a real difference in that, again, like all populations, cardiovascular disease is the #1 killer, but specifically, we see it so much higher in our Black population that we could really make a difference in outcomes in years to come immediately.
Yeah, excellent. So speaking of community, another question is there any thought of creating a HANU-like project in a diverse community?
Interesting, because we're working on that on the foundation side now, and again, specifically in partnership with this group on the north side, and again recognizing that a HANU in an urban environment would be very different, but also that there is a lot of really great work that was done in HANU and lessons that could be learned. And it's interesting in having the conversation that Gretchen and I have been having with this group. They're very excited about what HANU has done. And so I think sometimes, and how you might revamp that into an urban population. So yes, more to come. And yeah.
Excellent. So on that same line, MHIF used to go to schools to educate children about heart disease. Can we start this again to intervene early with children?
Yeah, I think that that's also one of the areas that we're looking at how we most effectively do that. And, is there opportunities to train the trainer and make sure that we're delivering this education and that people can see this trusted resource and also have it from folks that look and live and, hang out in the communities with them.
Perfect. Thank you. Just a couple more here. This one's actually specifically for Dr. Bennett. But what is the success rate, or what are the success rates post-heart transplant between Blacks and whites in terms of their longevity?
So what are the success rates post-heart transplant looking at Blacks and whites? Good question, and I don't have a specific answer, and I would be it would only be a guess that there's a difference, and so without the data, I don't know.
Thank you. So there's one last question, and this is for everyone. But what, in each of your opinions, do you suggest are actions that we can take at an individual level to bring about more equity in healthcare? If you had a magic wand and could implement one intervention at every clinic level, what would you suggest would help bring about more health equity?
So that in thinking about that, I think that we shouldn't take for granted that we are aware that there are these differences. So in terms of an intervention that we can all do, just be mindful of the fact that there are disparities. Be mindful of the fact that each of us might bring our own biases and prejudice to the care that we deliver, the interactions with our patients. And I think that awareness can go a long way to change behavior. So while there are things that we can do on a policy level, and I think on an individual level, it starts with awareness, followed by education.
So I'm really excited about the opportunities to be looking at populations ongoing. So in our data, making sure that we're collecting racial and ethnic data with our research, making sure we have objective goals that are measurable in terms of enrollment of racial and ethnic minorities, with the goal to representing the population that we serve, both urban and statewide. And then clinically, I'm excited to hopefully, not hopefully, but actually start to see changes specifically in cardiovascular outcomes, which I think we have the opportunity to impact. One thing that I do individually, and I don't know if it's right or wrong, but when I'm seeing patients in the clinic setting, I specifically call this out and I say, you know what, you're a Black woman. We have huge disparities in outcomes in our Black population and our female population. And so while I think your nausea is probably just GERD, I'm going to get X, Y, or Z test to make sure I have an objective indicator to say what this is or isn't. So I frequently have those conversations and sort of take that elephant in my mind out of the room, so they know that I'm aware of these disparities, that I'm giving them the very best treatment I possibly can, and just kind of raise that awareness. Mario, do you want to add your 2 cents?
I would also say that the magic wand, I think, is to take out the biases. To simply look at every patient as if you had no bias. Hopefully that, I mean, it's not possible really, but the magic wand would be that, to look at every patient as if there's no bias and do what you always do, and without being influenced by your biases. But I think that's, you know, we are making choices for patients based on what we think, how they would follow up. I mean, let them make the choice, right? So you offered out everything to them, and it's their choice at some point not to follow up. Also our job to make sure they can follow up, obviously. But I think to eliminate the biases, if you could do that as a magic wand, I think it would help 10, 20% more patients immediately. But unfortunately, we see that already in our little study, how people, you know, are not quite equally treated by their symptoms based on whatever bias there might be.
Yeah. I know one of the things that we've talked about is being able to have more of that objective type of, okay, you know, how do we have both from a clinical and patient perspective? You have these symptoms. What are possible things that should be considered to start to level that playing field? And that's been some of what's come up with the Maternal Mortality Review Committee. So then it's up to the patient to choose if they want to get help this way. But if you continue to have shortness of breath after you've delivered a baby and nobody's looked for a PE, here's what you should be asking about, you know, and trying to level it. So see.
I like Jay's question. I like the online question. You know, why are we not going in these communities? And why are we not doing old things like going to the school? You know, I think that if we want to make a difference at MHIF or MHI, we simply have to do that. I mean, if we work closer with HCMC, we see more patients. If we work closer with X, Y, and Z, we will see more patients, you know, but we have to show our presence, however, either voluntarily or actually as living clinics. And then even if you start a study, you will see these pipelines being created. I'm pretty sure. It's just that if we're sitting here and just expecting it to happen, it's never going to happen.
And one of the pieces that way to the research part, you know, like the University of Minnesota, for instance, has URAC, which is a center that they enroll patients in on the north side. And I think as we look at how we do research, where we do research, and what COVID has done to all of this, having small locations that way that are in the communities, that again, there's a small, it doesn't have to be a huge institution, but also makes it easier for people from a transportation and timing and everything else perspective, and doesn't have to be cost prohibitive in terms of sharing spaces and things like that. So all sorts of fun stuff, but I'm glad to hear people are endorsing that type of strategy going forward.
All right, thank you.
Thanks.